So I am not new to payment reform. Many of you have had a chance to have an encounter with me related to episodes of care. I have changed roles, and right now I am working on the MTM pilot project. So I've been given 10 minutes, and what I'd like to do in that brief time is provide you with an introduction, some information and contact information, some resources that you can contact us and find out some information about the MTM pilot project. And so what is MTM pilot project? It is medication therapy management. It doesn't roll off the tongue so easily, especially if you haven't had your second cup of coffee yet. So it is MTM. And so with that, I would like to provide you a little bit of background. Can you hear me? I'm really not used to it. I'm pretty loud usually. So recently, legislation was passed, House Bill 628 and Senate Bill 398. And with this bill, it tasks TennCare to implement, design and implement an MTM project. And with that, it is anticipated, it has a short ramp up. It is anticipated to start January 2018. So it's right around the corner. With this, it will have those triple aim processes in mind. So high quality, cost effective services, hopefully to help you with your outcomes, improve patient satisfaction, and such. So with that, that's a little bit about that background. So remember, it's going to start January 2018. And let's switch gears to patient eligibility. Did we switch? There we go. Okay. So patient eligibility. These are TennCare eligible patients ages 2 to 64. And what the pilot would like to look at is really two stratifications. And one would be that high-risk stratification. So in your care coordination tool, using that a CDPS+, it's going to look at medium high, high, and critical. So your pharmacist will look at that high-risk stratification, those top 16%. Those are those patients that have chronic illnesses and multiple medications. Second part of the pilot is going to be looking at targeted disease states. These are going to be focused in on pediatrics. These are going to be pediatric patients that have asthma and diabetes. Okay, and these are patients aged 2 to 18. Okay. So how are we going to get started? So first of all, the pilot is going to take place in the patient-centered medical home and Tennessee Health Links. This is voluntary. It is not mandatory. So it's up to the practice if they want to participate. So having said that, if you are a practice that already work in collaboration with a pharmacist, there are going to be 4 key elements that you're going to want your pharmacist to have, and that's going to be on the next slide. Second, if you are a practice that is interested in participating, kind of digest all this information, take it back, and look at the benefits, you can reach out, and you don't have a pharmacist in mind, you can reach out to Tennessee Pharmacy Association, Micah Cost, and his information is right here. I think the slides will be available to you, so you'll have all the links available to you. So if you're interested but don't have a pharmacist in mind, he'll help facilitate that process for you. Okay? All right. Next, so how can I get my physician to participate? So first, they have to have a TennCare ID. It's a Medicaid, so with that link, we'll launch right into the portal, and they can start that process, okay? And then the next 3 you can work on after you have your TennCare ID number. You need to have a collaborative agreement. There's some guidance. TPA has set out some guidance for that collaborative agreement, and that is also on our MTM website, so you can have that information as well. Then you will also need to have a network agreement and credentialing for that pharmacist, and that's going to be MCO specific, just like you would for your regular practice. And then fourth is the CCT. It is required for the pharmacist pharmacists to utilize the CCT tool for documentation. And so as such, they are going to need registration, training, and access. As part of that process, the state has worked on an automatic process to get them registered, and that will begin November 10th, that automatic process. It's manual before that, so I'd kind of wait till November 10th. Okay? Did it flip to characteristics? Terrific. All right, so this is just, I'm not going to read the slide, but this is a little bit of the characteristics of MTM Pilot. There are several pilots and programs out there. CMS has one for Part D. Minnesota has run a pilot. New York has run some pilots as well. But in essence, you're going to ID the patients in that CCT tool. You're going to look at that risk stratification and disease target. They're going to reach out to those patients, do a pre-review, looking at treatment gaps, duplicate, and any interactions. They'll have that encounter with that patient, and then they'll document in that tool. They'll reach out to the providers, have some good communications both with the provider and the team and with the patient, okay? And again, that documentation will be in that CCT tool. Okay. Sounds redundant, doesn't it? Because T stands for tool. Alrighty. All right, finally, as part of the pilot, pharmacists will be reimbursed. They will be utilizing CPT code 99605, 606, and 607. There are 4 key modifiers that they will be utilizing. U1 through U4, it's going to delineate those disease-targeted states and risk factors for that. Okay. And finally, what I would like to offer is some general information on MTM. We recently launched our MTM website, so that is full of information. So I would direct you to that website to read up on the project. If you have any questions, feel free to reach out to me at TennCare@10gov. And then finally, again, if you're interested in trying to find a pharmacist interested in this program, I have connected you to the Pharmacy Association website as well. So I appreciate your time, and if you have any questions, I will be around for a part of the morning and afternoon. So if you have any questions, please feel free to reach out to me, and I've also left my cards at the front check-in desk. Thank you for your time.
Good morning, everyone. Hey, I'm Victor Wu. I'm the Chief Medical Officer at TennCare, and this is my first chance to get to be with you guys, and thanks for the opportunity. I just wanted to ask a couple questions about this. How many people here actually work with pharmacists in their practice right now? I'm really curious. Have pharmacists either part of your team, or at least you have a coordination with your team? So some folks, and so I think just to give a little bit of background on the MTM pilot project, many of you guys know that pharmacists oftentimes see members 12 times a year. They'll see your patients 12 times a year. They go for their monthly refills, and they have a different set of touch points that is different. So the legislative body of the state has a lot of pharmacists that are legislators. We need to get more doctors on there or providers into the legislature. But they, I think, in conjunction with TennCare, work together to think about what ways could they kind of support the patient experience. And what we recognize is that, gosh, you guys in the PCMH level do so much work. You're really practicing a lot team-based care. You're really beginning to develop additional support staff, whether it's through care managers or through nurses and through your providers and your doctors, your NPs, your PAs, that the pharmacists, if they're going to be part of the team, need to really work closely with the primary care provider. That's one of the most important connections we want to make. And so the NTM pilot, the thought behind it, just so you guys know, is it's really a chance to kind of bring in another member of that team, but underneath the way that your practice works and a way to support your doctors. And so, as Jackie mentioned, that one of the requirements we really want is for a pharmacist to work and to sign a collaborative practice agreement with your primary care doctors. And so if you want them to work on when pharmacists find a member and they talk with them about a transition from the hospital and feed that back in a certain way to your doctor so they know what happened in those conversations. We want to make sure that the PCP and the PCMH stays at the center of that relationship. And so the whole goal of the pilot is to find ways to get pharmacists to be part of the extended care team, working with and in support of the work you're doing in the primary care and in the HealthLink behavioral health home, and to really begin to develop relationships on that front, to refer high-risk patients that you might need extra help with or don't have time to spend those extra 25 minutes reconciling that member's medications. I think of a great example is anytime a patient gets discharged from the hospital, how many of your doctors, or if you're a physician here today, come in and the list that they get from the hospital discharge is about two drugs are right and the other 18 drugs are new, and you have no clue, and the patient doesn't know what they're taking, and that happens all the time. And so that would be a great example of a time where if you could say, all right, let's get a pharmacist to go through and reconcile all the drugs that you got from the hospital discharge and you're taking in your primary care, and let's make sure we're on the same page, give them any instructions. I think those are the types of things and interactions we want to have that are productive and supportive of the PCMH and in the HealthLink situation. So the goal of this really is for you all to find opportunities to work with your pharmacist colleagues, whether you already have one embedded or in the community, and really find another touch point to kind of wrap our arms around our patient population in the community. So I hope that gives a little bit more context. There are nuts and bolts of how that has to work. We want to make sure we track, and we want to make sure that the pharmacist is really meeting high quality care delivery. We want to make sure the pharmacist works with you all to sign a collaborative practice agreement to meet your expectations. We want to make sure the pharmacist is really integrated in the care team. So that's kind of the requirements that Jackie just went through as well. So with that, if there are any questions, we want to make sure we answer those. But I'm hopeful that this is just another tool in the toolkit for all of you all in your practices, whether in the PCMH or in the HealthLink, to really find a different opportunity to engage a patient, because we do know they have to go get your medications. We do know they're following the pharmacist. So just wanted to add that context and hope that it's something that is a productive and good partnership for our primary care and our HealthLink providers. I think it's going to be a good way to continue to find opportunities to engage that patient anywhere they are or anywhere they're touching the healthcare system. So I'll stop there unless there's any questions. So thanks for letting me kind of hijack and give a couple more thoughts.
But glad everybody's here. And this should be a very interactive session, if you will. But if it gets out of hand, I hear security is not far away. So we do have a parking lot, so if we need to put some things in the parking lot that may not be addressed this morning, if we need to address it later on, we can also do that. And there is a mic going around, so if you have a question, Pam in the back will bring you the mic so that we can hear you. So I have the panel introduce themselves, starting with Dr. James.
Hey, good morning. I'm Shawn James. I'm Chief Medical Officer for Blue Care, pediatrician by background. So forgive me if my examples that I give today are all pediatric. I try to throw in a few adult examples when I can, but I'm really happy to be with you all today. Thanks.
I'm Capricia Morrow. I am with AmeriGroup. I am the provider engagement lead for Middle Tennessee, and I've been with AmeriGroup for about 2 years, and I'm happy to be here. I see a lot of familiar faces.
I'm Mike Sandwith. I'm Vice President of Payment Reform and Transformation. I'm responsible for episodes of care, PCMH, and Tennessee HealthLink, and coordinate that with the state. I've been in healthcare for 33 years, and I use a lot of oil of Olay. Okay.
Well, all righty then. Could everyone hear the panel in the back of the room? Do we need to do any volume adjustments? Nothing worse than sitting there like, I really can't hear, but I'm not going to tell anybody. Back corners, we're good? Okay. Question number 1. What services do the MCO offer that would be useful for PCMH and or HealthLink practices to know about? And we'll start with you, Mike.
Oh, man, a lot of pressure. We use something called UHC on Air, and we also have a library of educational webinars. UHC on Air has been very, very successful with episodes of care in terms of breaking down how to read a report, what is risk methodology, those sorts of things. So we're looking at expanding that for PCMH and Tennessee HealthLink so that at any point in time you can go out there and get a live more or less a tutorial about a certain issue that you might, whether it be a report, we're looking at doing something on care coordination tool, and it's a very effective way that allows you to get some basic information, and it also will produce some questions which you can direct to somebody within either THL or PCMH team.
Great.
Next.
Any questions for Mike? Would you like to add something?
Yes, so at AmeriGroup, we have a VIP model. And how that's structured is you have the provider engagement lead, which is myself for Middle Tennessee, and you also have a clinical liaison, which is Julie, that's sitting over there in the corner. And you also have a program manager, which is Trio Shipman, and also a behavioral health manager, which is LaWanda, who's sitting kind of in the back of the room. So you have a team that's working together that is available to you at any questions that you have. So if it's something that's provider services related, then that would come to me. I'm your direct point of contact. If it is something, of course, that for the THL or for PCMH that's working directly with the THL, you could go to LaWanda or to myself. You also have the clinical liaison, and the role that Julie plays is she's available primarily in the beginning when we were ramping up on the CCT tool, was giving out lists that you could target your patients and your panel and do outreach to drive the results with the quality. And then, of course, the program manager, Trio Shipman, who works directly with the state, and we all work in partnership together.
Great. Thank you. Dr. James?
So always hard to go last, right? You want to say ditto. We got all those things too. So yeah, I mean, I think you'll see that, certainly we're organized in the same way. I think we all, as we worked through this, have kind of worked through, how did we organize ourselves as MCOs to interact with all of you. For me, the most important thing and exciting thing about this program recently has been that, for a long time, we all as plans have worked on a lot of this stuff, right? We've done lots of outreach to members and education through all sorts of things and work with providers one-on-one. But now we finally got this format to interact with all of you on a regular basis about real life sort of examples. And so one of the things that I would just sort of add and encourage everybody about is that I think for me that's been one of the things that's been the most valuable, for us to really be able to, through our teams, meet with the practice and not just say, well, wow, this whatever isn't working very well, but to be able to talk about, well, for these 3 patients, and let's work through the example for that particular member, that we've been able to sort of walk through the process and find opportunities where we can work together better. I think that early on, things like help with transportation or connection back to our case management teams for a really complicated case where you need somebody to go find them at their house instead of just calling them on the phone. I think all of those are things that we all have, and I just would encourage you to think about it on that sort of big scale of your entire population, but also sometimes it helps to pull out a specific example and work through, because then we can kind of learn and spread that information from that case.
Great, thank you. Well, since we're here with you, Dr. James, we'll go to the next question. Are there plans for additional services in the future that would be helpful for PCMH or HealthLink organizations? Anything on the rise?
I think for us, we're definitely continuing to learn. You heard folks mention already, so we've got Wave 2 coming up with 40 more practices, and so part of what we've got to figure out as plans is, how do we continue to scale this, right? How do we find those things that in the first wave were really useful to all of you and get those quickly to the next groups? And so I think that's one of the things that we'll continue to look for. Is it too loud? Oh. Is it too loud? Oh, sorry. I thought I was
Talking to the short person that needs to put the mic shorter.
Oh, I thought he was telling me I was too close. I was like, no, I don't want to be too loud. But so for example, for us, we've started to look at what are the sort of quick resources we can get to you first, and then work through specifics for each practice. I think I mentioned transportation earlier. We're continuing to work on that and find ways to get to sort of make that more streamlined for practices, because we hear a lot from folks that transportation to and from a visit is a big barrier for the folks that don't come on a regular basis, and so we want to continue to work through that. And we know that that's different in the urban and rural areas. So I guess those are probably the 2 things that I would highlight for us that are on the horizon.
Great, thank you. Capricia?
Okay. Well, I don't know that there's anything necessarily a specific service that we're offering in addition. I know that, or I hope I'm not jumping the gun, the state was working on a letter that would help some of the non-engaged providers, some of the providers that are not necessarily a part or affiliated with PCMH, that the THLs were having difficulty getting information and kind of communicating with, and even if there are PCMHs that are partnered with a mental health provider who's not a part of the THL, letters to give them information and help them understand exactly what PCMH and what THL are. So I know that's one thing that's kind of on the horizon that should help some of the concerns with the measures that overlap between PCMH and THL.
Great, thank you. Mike?
I'll just, again, talk about UHC on air, but I think a lot of the things we'll add, and not so much in services, but support, is things that I've learned that have been beneficial for providers with episodes of care. And so that will be looking at best of practice and other aspects that we can pick out, and those providers that are doing well, then we can kind of figure out what they're doing well and expand that to other providers and share that information as well.
Okay, question. We have a question up front, Pam. A couple questions. So think of the questions you may have for services that the MCO provides.
Hi, good morning. I'm Dr. Evans at Swanee Pediatrics. So the care coordination tool is something you all provide. Is that correct, through the TennCare Bureau or through your, I'm not understanding where the care coordination tool comes from. Is it from the TennCare Bureau?
Yes, the CCT is through TennCare.
Okay, so each one of the MCOs has their own log on and patient patient lists. Is that correct?
That's correct.
That is correct.
Okay, so we had thought that the care coordination tool actually communicated with the MCOs, but we learned recently, and correct me if I'm wrong, that it really is just a way to organize lists of patients for us to go through it. It's not, it doesn't communicate if we've given a vaccine or if we've seen a well check. If we change it in that list, it doesn't communicate with you all. Is that correct?
Well, all the MCOs and anyone working on PCMH or Tennessee HealthLink, all of those people have access to the care coordination tool. So they can go out and look specifically at your specific practice, if there's gaps in care, membership, that sort of thing. And so that's where it was important for the MCOs to be able to have access to that so that we could look at those specific practices so that we could be a partner with you as we sit down and determine how to maximize the information that's in the care coordination tool.
So it is a way of communicating.
Yes.
Because our EHR is very rigorous, and so we can do reporting through our EHR, and we didn't want to have to duplicate that effort, but if it really is communicating with you, then it sounds like it's an important tool to use.
So maybe I can jump in and clarify a little bit. So there is the care coordination tool called Altruista that's through the state. That's the comprehensive tool, right? That includes, so you can go to that tool and look at your list of members and information on members from all three plans if you participate with all three plans.
Okay.
That tool is populated with claims data that comes from all of us, with feeds from the immunization registry, pharmacy data, and it continues to have what are called ADT feeds from hospitals about admissions and discharges and transfers they're continuing to add hospitals over time. Each of us have, as plans, all have our own systems as well, right? So for us, it's one called Blue Access. Everybody's each got one that's their own. The thing that's maybe different is, like, I know for Blue, you can go into our system and attest to the fact that you gave a vaccine. That won't show up in the Altruista system until the claim or the vaccine feed goes through. And so there are some differences about that, and I think the thing that's important, and I think all of us can work with plans on how to work with those things together, is that there's a lot of benefit in being able to look at Altruista and look at your whole panel, right, across, so you don't have to do sort of three different things with the three of us or as plans. But there are also times where you may want to go look at one of our sites because there may be something that's there a little faster, a little different, a little more, whatever. And over time, more stuff's going to get into Altruista, and it will have more of that. But I think part of this is sort of the growing pain of a new program, right, where we're consolidating sort of resources over time. So that may be That may be part of what you're seeing is the difference in those. There are a lot of specific rules for us as plans about when you go in our system and tell us that you did something, you have to do it in a really specific way for us to get credit for that. And so, so those are all things that, with our specific plan reps, we can talk to you about.
Yeah, and the other thing is you're going to have timing issues
Yeah.
because of claims.
Claims.
So it may take a 30-day or it may take longer for that. But really, that's going to be the registry where, as we get better with data, if you look at ADT feeds, when we started out, we only had 2. The latest list I got yesterday, they're up to 79 hospitals. So I would also reach out to the teams, and so that you can get an update as to what hospitals are in production, what are in QA, and what's in the pipeline.
Can I just add something to that? So I think your question is so relevant about if you're using the tool to communicate with the MCOs. The one thing you gotta keep in mind is to get credit for closing a gap in care, to make sure that it shows up on your report, it has to go through the claims.
Yeah.
So if you just attest to the tool, it will not translate to, I closed the gap, I got the HEDIS credit. So I just want to make that clear that the tool, can help you see your risk stratification, it can help you see the alerts from the hospitals, it can do a lot of things, but it doesn't, HEDIS hasn't authorized it to be an accredited source of attestation. Does that make sense?
Yep.
So you still have to submit all the, if it's a CPT2 claim, or you have to still submit all the codes to get that.
Thank you, Carly. That's Carly from TennCare. Thank you. Was there another question over on this side of the room earlier? Any other questions about support of the MCOs before we press one on the left side?
Hello, I'm Mary with Covenant Care Practices in Clarksville. I know that we have Blue Access for Blue Care and Availity for AmeriGroup. Is there anything for United Healthcare that we can log on to? The UHC on air we have not had success with, and it doesn't work very well for us, or sometimes at all. We have
Interesting.
access to Link, but we're not sure if that shows us gaps or our patient list, or if there's anything we can use for UHC.
We will not use Link yet for the reports. Episodes of care reports will be put on Link. So if you've got an issue with UHC on air, if I don't hear about it, I can't really
Sure.
figure
And
it
we
out.
just recently
But
figured
what
it
we've
out.
had is a separate secure portal for that, and then we've sent out those reports periodically. But what are you trying to access in terms of?
Our gap reports.
If I must
Stacey, yeah.
add, I'm sorry. I'm Michelle from Covenant Care in
Okay.
Clarksville. I actually have been able to get in, and I've gotten in through the Link, area, which I have one with me, the Patient Care Opportunity Report. Is that the same thing as, like, the gaps in care? I was able to pull that
No.
up. It's not? Okay. Okay, but yeah, so we don't. So are you guys coming up with something like how AmeriGroup has the 360, Patient 360, Blue Care has Blue Access?
I'll have to look at that and just get your input of what we can do with that.
Okay.
So I think
Because, yeah, currently, right now, we're just, hoping that we get current lists from our.
you want current list of members?
Members, gaps in care.
Gaps in care.
Mhm.
Okay, I'll get with Stacy about that.
Okay, thank you.
One question. Okay, Pam, have one more on this side. Thank you.
Thanks for helping me with my weight loss efforts.
You don't need to go to the gym later. I think you got it good. This is Constance. I'm with TenCare. I just wanted to clarify, because it seems like there's been a couple of follow-up questions about where you can go within the MCO's own portals or their own build-outs to find the information that you're looking for, like gaps in care or a list of members. And I really just want to emphasize that the one-stop shop for all of this information is actually the care coordination tool. I know there's been a lot of hesitancy in using the tool because of questions about, accuracy of the data, but we've come a long way in fixing some of those issues that are in the tool. Our error rates are down very low at this point. I will say if there are continued concerns about information that's in the care coordination tool, a lot of times those are errors that can be addressed and addressed pretty quickly if you just make sure to notify someone either at the help desk, and I know we've given you all that phone number and email address, but also, if that seems too daunting of a task, absolutely feel free for HealthLink to send myself or Mary Shelton a direct email with any provider questions or concerns on the CCT. We'll make sure those get into the right hands. Or Meredith Gonson, who spoke earlier, she kind of oversees PCMH. So if there's specific questions about that, but one of the really good things about the care coordination tool is that all of the MCO's data is in one location. So you don't have to, navigate the variability in the portals. Absolutely, the portals serve their own purpose, especially for things like provider attestation for HealthLink, but we really want folks to move towards using the tool. MTM is going to be linking up with the tool. So it's actually really important that we try to get everybody using the same platform to get that information. And that, again, if there are errors or inaccurate member information that you feel like you're getting from the tool that doesn't match up with your records, reporting that to us so that we can, check into that and see what's going on.
One of the other things that I might add, just as sort of an overview, is that I think it's important to sort of step back and remember what transformation that we're going through right now. So, a year ago, the way I could interact with a practice at Blue was to bring you a list of members that was a gap list, that we called it, that said, these are people who haven't had this. And we really want to, in the next few years, get to the point that it's not always about chasing a list, right? It's about that things have transformed in the way that we communicate with you, the way that the practice operates on a day-to-day basis, so that those things like when you look at a list of patients that you're going to see for the day, you've anticipated, wow, these people that are coming in, these 5, I need to make sure I get a flu shot, or these 5, I need to make sure I get a diabetes screen, so that we are, there are some things today that we still have to work on from lists, but that we really want to transform to the point where the processes in your practice change so that we anticipate those things, and that each time that a member comes or that you outreach and get a member to a practice, that all the things that are needed care for them can happen when they get there. So to me, again, I think some of this is a sort of growing pains as we transform from sort of the old way of doing things to what we see as this vision for the future. And for a little while, we're going to be in that tension of, we used to use this list, now where can we go find it in Altruista instead, and look at, the patients that are coming in tomorrow and make sure that we're prepared for those. But so I know it can be a little frustrating sometimes, but I think keeping that eye on, well, this is what we're trying to get to, which is really going to be an exciting place to be, and a lot more advantageous to our members is exciting.
Oh, and the light bulb just went on in your question. I'm slow. I haven't had a second cup of coffee. But what initially we had was a health registry for the ACO product, and that was where you were getting your lists. We had a discussion this week about, because once you become a PCMH provider, we kind of turn that data off to you all into the registry. But with the issues that have occurred with the care coordination tool, and sometimes your lack of confidence in it, that you want a supplemental backup. So we're in the process of now of turning those on that have become PCMHs. Felicia is going to be looking at that to see if we can provide you supportive data to support you with the transition to the care coordination tool. So, yep. Yeah, and I'll connect you with Felicia, and she can help you with that, because we just talked about that with the national team as well, so you're welcome.
We have it in the parking lot, so we can definitely address that
Yep.
in a bit. I'm going to go ahead and go to the next question if I can, and then if there's time at the end, because we have got some great questions, but I do want to provide some more opportunity to have this open dialogue. I'm glad you all are halfway awake. Kafrisha, if there are specific initiatives that a practice may want to work on, is the MCO able to help? And if they are, can you give us some examples of ways that they can provide the help to the practices?
Yes. So definitely, if a practice has specific initiatives that they're working on internally, we're open to partnering with the practice on those. Some that we have already set up are our healthy rewards, which is more of an incentive for our patients, where it's information that you can provide to them. If they're coming in for certain screenings, then they're getting kind of points or dollars that are added to like a reward card for them. And then also, of course, for the providers themselves or for the practices, you have the incentive of the Category 2 codes that we, of course, have the reimbursement of the $10 per code per member per year. So those are the incentives that we have that are available, but we're certainly open to the practice if they have their own initiatives that they want us to help with.
Great, thank you. Mike, any initiatives out there that you all could help with? What ways could you all help?
Well, I think it's really important, I think with any transitional program, that it's really key to set up those questions that you want prior to a meeting, to communicate with those people who are going to be in the meeting initially, so that you can really address them and not just, because communication is key to make this successful. And without knowing your issues, whatever that may be, it's a totally different transformation, and communication and building that relationship with that THL team or PCMH team is key for you all to make that transformation. And I think sometimes we kind of let things slide a little bit, but I think you've got to be proactive in making people aware of what your issues are and being able to address those.
Great, thank you. Dr. James?
I think there are lots of things that we can partner with around outreach. So certainly as plans, we've always worked on, how do we find those members or reach out to remind those members who haven't been in for care. And more now as you're working on your quality scores, that becomes an important part. So all of the kinds of things that we do around outreach, then we can work to customize or partner with your practice. So anything from a mailing that we might, make sure that is designed so we can do the back work, but it looks more like it came from you, because we know that patients tend to respond better to the postcard from their doctor rather than from their managed care plan. So we've done some work to sort of match those things up, to all the way to making phone calls on the behalf of a practice. We're calling for your doctor so-and-so to help schedule your well child visit, that kind of thing. So a lot of things around outreach. The same thing that was mentioned around incentives. We've done some things where we know for certain things, adolescent well visit is one, that a member incentive, some sort of entry in a drawing or a gift card or that sort of thing, can be really successful. And so just your practice knowing which of those things have some incentive from us associated with it is something that we can provide. And that helps when you're calling a member or a family to schedule an adolescent visit and to say, well, there's also this incentive that you can get. So I think a lot of things around member outreach are sort of some of the easiest or quickest things for us to partner with. And then there's certainly always all sorts of educational materials, either for your offices that we all have or for your providers. I mean, I think all of us now have the big Bright Future schedule that's laminated that we give to everybody that we can think of to give to. And I've seen them in lots of offices now in every provider room so that folks can refer to all the things that need to get done at those well visits. So I think those are some examples that I could think of.
Great. Yeah, the West, we learned yesterday that a bus ticket and a Wendy's gift card got them in most often. So just note on that. It
Where do I
works.
sign that?
Any questions on what we just covered for initiatives or how the MCO can assist you with your initiatives? Hi, yes.
Is there any discussion, from our perspective, they're patients, they're our patients, so we don't have them in silos of, Blue Cross Blue Shield, United Healthcare, TennCare, or not, they're our patients. And so it's artificial for us to see it in silos. Is there any discussion of aggregating data and looking at quality data from a practice perspective and not the different MCOs?
I'll take it.
My answer then.
Because I heard a couple people snoring, so I'll go ahead and take it. That's the $60,000 question. We've been through that with episodes of care. You participate in episodes of care, you get 3 reports, 3 MCOs, 3 quality measures, take back payouts, whatever. So I think it's been discussed in the past. I don't think we've moved forward with that, but I think we've talked about in the past that could there be a secure health database at the state of which that data could, like an HIE, that could be put in there and when you'd be able to access all of it. But that's quite a bit down the road. And that was a discussion, I think. I've only been at United for 2 years, so I think that was a discussion about 18 months ago about that. But yeah, we've had a discussion on episodes, and it's going to raise its head up again when we talk about THL and PCMH as well. I'm all for it, so if I can help you, let me know. Sure.
I can start with that. I mean, I think probably it's true of all of us, but I know that for us, we are working on some pilots with that now. One of the things that's important to understand about the school system, and you guys probably all know this, is it is different by school district, right? So it is governed at the local school board level. So there are not always the same people in the same role in terms of, a district may have a nurse that goes to several schools and is not just at one school. So sort of figuring out on a local level who it is that we partner with and how. We've done just some pilot work in East around specifically kids with asthma and partnering with school nurses so that they can contact us so that we can help connect folks back to their patient-centered medical home there or to their primary care provider. So we definitely are looking at that. It won't be the same in every school district, though, because it's not sort of a statewide thing that's the same in each one. But we have had some success with a couple of PCMHs who already that practice works pretty well with their school nurse, and we've been able to start on some of those things, too.
Thank you. Did you give the mic to someone?
Yeah,
Hi,
I'm
Randy.
sorry, I've got the mic. I just wanted to follow up on a couple things that you said, Dr. James. First, I hear the issue that particularly the HealthLink providers have significant issues at times locating their members. And so just kind of, aside from what you suggested, are there other initiatives that the MCOs are involved in or are considering or are planning to help with that whole issue of locating members that are just, that just transient or don't have accurate addresses, phone numbers? Are there ways that you're working on, trying to help that out or help these people out other than what you suggested?
Yeah, I mean, that's probably the toughest thing in Medicaid, right?
Yeah.
That is the toughest problem. So we're certainly all working on that, I think, all the time in a lot of different ways. One of the things that we've looked at is sort of segmenting, okay, the group of folks who have no claims at all, or the folks who have no visits to a primary care provider but have other kinds of visits in the system. So they've been to an ER or an urgent care or a hospital admission. Working for us through our what we call transition of care program, to try to make face-to-face contact while they're still in the hospital so that we can get them back to who it is that they're assigned to. So we are doing a lot of things on that group first.
Right.
I think a lot of us have care managers or care coordinators or case managers that work around other places that we know to look, like homeless shelters, other sort of social agencies that may interface with those people that, those patients that aren't, coming to care, but in those kinds of things. I think we've worked too on a lot, with a lot of practices on even that step further of what we call missed opportunities. They may come to your practice for a sick visit, but that's the only things that they have, so their sort of preventive and primary care hasn't happened. And so being able to try to convert some of those visits to both a sick visit and a well visit when that's feasible is another initiative that we've looked at. So most definitely, I think all of us work with companies to try to find better phone numbers and better addresses, and go drive to their house when we can't get them on the phone, all of those kinds of things. So definitely, I think those are all things that we're working on.
And I was just going to add to that. At AmeriGroup, we're using the LexisNexis to find better contact information for our members. And then also, just if it's, I think when Julie is originally going out and talking to some of our groups, she's providing them what's like a new member listing, or members that have patients that haven't been seen. So if it is someone that is associated with a PCMH that has not come into your practice for quite some time, to try to narrow down through LexisNexis, how do we get better contact information to go and outreach to that specific patient? And of course, just to add on to the issue with the care coordination tool and making those adjustments, if it's information that's inconsistent, of course, let her know. We can always try to reconcile that. So if it's something that's different from our system, from what's in the CCT tool.
So when these kinds of things happen and you're identifying someone that, say, a PCMH or a HealthLink can't find, are you actively inputting that information into the CCT at this point, so that the providers that are assigned to those members can access that information?
So if it's new information that we're finding through LexisNexis?
Exactly.
Yes, so if we identify that the information is accurate coming out of the LexisNexis and we make that update, yes, we're feeding information into the CCT tool.
Okay.
Yeah, it goes through the state to the CCT tool, so like we wouldn't directly go in altruist and update an address, for example, but we get the member to update that address or phone number, and then it feeds through the TennCare system to update that tool.
Okay,
Yeah.
and then the other question I had for you, particularly Dr. James, you mentioned, you mentioned your capabilities around care management and helping out with, I'm assuming patients that are hospitalized or hit the ED. You may or may not be the first line of, intervention, because you're doing pre-auths the minute they hit the ED, and I don't know if that hit, if that comes first, or if someone at the hospital is entering the ADT information into the CCT system. So it seems like there's an opportunity for us to all kind of work together to make sure. And
Hey, this is Constance. Yeah, so that's another good point. Admissions, discharge, and transfer information. This speaks a little bit to maybe you have a member that ends up in the hospital, but you haven't necessarily established a relationship with them. To date, we have about 42% of the licensed hospital beds in the state of Tennessee feeding their admissions, discharge, and transfer information into the tool through the help of THA. And we're still on target by the end of this year, so the end of 2017, to have all licensed hospitals and beds that are with THA in the tool, so that information would feed directly into the tool. So you can actually see information based off of the admissions, discharge, and transfers, and that is actually almost in complete real time. So you would be able to see that for that actual day, and then if you have a particular event, everything that's associated with that event kind of tucks under each other, so you can see if there was an admission and then a subsequent discharge. And I know our health links have been using a lot of that information. They had previously through the help of the MCOs, because previously some of the MCOs had been feeding that information directly to the health links, but now all that information is collected in the tool for all of your members. So if you have an ADT for someone who is one of your attributed members, that will show up in the tab of the tool. And I know we have pretty exhaustive training up in the training materials to show you how to access that information and follow up. Again, we're trying really aggressively to get the rest of the hospitals in the state online, but we're really, targeting in on that and trying to get you that information, because it's exactly what you're asking for, where, okay, but someone's in the hospital. And so to Dr. James' point, that's where we're trying to get you that information, where we might have someone that's accessing this system at a different point of care and connecting you to that member at a different point, because we all know our members use lots of different aspects of the healthcare system and beyond, and so then that way you can connect directly with those members while they're in the hospital. Go ahead and make that connection with them and make sure that follow-up is scheduled, et cetera, for folks that might end up there because of an asthma exacerbation or diabetic ketoacidosis, something like that.
Great, thank you. That's great news that by the end of the year, all the hospitals will be fed into the system.
Yes,
I know
our
that
folks
that's
have been
what
working hard.
A lot of the practices are waiting for that. All right, I've got the 5-minute hook, so we're gonna go into speed dating mode or speed mentoring, or I don't know, that was before my time, so be sure you let my husband know that, because we've been married 20 years. Okay, MCOs, can you give me an example of a successful working relationship between the MCO and a practice? And do you have any advice on how PCMH and health links can work together? Ready, Capricia, and go.
Okay, so I'll try to make this really quick. So I think the biggest thing is going to be, of course, the communication, and for us also information and resources. So if it's the care coordination tool, of course, is what you're using primarily, and of course the reports that we're bringing out to you on a quarterly basis, that's your kind of like your Bible. I hate to say it that way, but that's kind of like your truth of what we're receiving back at the MCO. So in the probably, I kind of feel bad calling out specific groups, but for our high volume groups, I'll kind of pinpoint with Capstone. We kind of hit the pavement running with that group, providing lists, getting feedback. What is it that you need that you don't feel like you have from a resource perspective? I know specifically we've given lists of here are all your patients that are receiving ADHD medication, if that's going to help you faster to be able to outreach to those patients and drive up that quality result. If it's something specific with, I think it was they were trying to access their asthma patients from a population health perspective, not just kind of looking at a list, but from all of their patients that were having issues with asthma. So really just having that open dialogue. I'm available, majority of the time by phone or by email. Also, Julie is as well. So it's just having that open dialogue from a low volume community care. We have worked with them previously on our shared savings. They fed right into PCMH. We've always had that open dialogue of what do you need, what questions do you have, and a quick turnaround. So that's kind of what drives our success.
Thank you. Mike?
I'll just have to ditto that, but I do think that recognizing that both the MCO and the provider are navigating THL or PCMH together really makes the process easier, and again, you're talking about open dialogue and questions. And I think that's really the initial step, that you've got to build that trust, that you can communicate, whether good, bad, or indifferent, with each other to kind of address that issue.
Great, thank you. And Dr. James?
I guess in terms of the question about THL and PCMH working together, I think it's exciting that we're adding as many PCMHs next year as we are, because this sort of issue of a THL member who goes to a primary care provider who's not part of the PCH program will get less and less as the program grows. And so I think that that's a good way that we continue to work on that. We've worked with some specific practices just to try to look at, okay, who's your closest health link? The meetings like this where you interact with each other to collaborate on members, I think is really important. And then I guess the last thing that I'd just share real quick is that I think for us, and in sort of partnerships with all of the practices that we've gone to meet with about those reports, that I sort of segment the way we look at the reports with practices into sort of 3 big buckets to approach, and that's kind of helped guide strategies for improvement. So as we look at it, is it something that we think first is a data issue? Is this quality metric something that you know you're doing all of the time and you're sure about it, but there's something about coding somehow that we're not getting the data that gives you the credit for that? And then we've looked at, is it some coding education? Is it some other sort of issue around that we need to do to capture the data better? Or is it an issue of outreach? Is it about we've got to get the member in to get that service, right? So a lot of the EPSDT screens may be that way. Is it that they're not, and then the strategy is going to be around outreach? And then finally, is it something that then it's not about data or about outreach, we're seeing those members, but is there some process or activity change within the practice that needs to happen to make sure that you do this lab test or you do this intervention while the member's there, and then, how do you work through that process change within the practice? So I think for us, sort of those 3 big categories of how you sort of first tackle approach to those, making improvements in those reports has been a really helpful way to sort of categorize those things. And folks have had, success in all of those areas by looking at those in different categories.
Thank you. Time is up, but are there any burning questions that we need to put on the parking lot before we run out for our networking break? Right here, burning. Quick.
I'm not good at this, but my question is, Bill, and I'm a case manager, I work for Unity. When I have a client that I refer over for behavioral health care, that patient is attributed to us. For behavioral health care to then bill that patient, they've got to take that patient away from me so that they can bill. Is there any way that you guys can fix it so that people can bill for the services they're providing? If you're doing therapy, bill for therapy. If I'm your case manager, allow us to do that. But all this pulling back and forth with the
Attestation.
That word.
Uh-huh.
All that back and forth, sometimes you don't even know that your patient's been taken.
Yes.
Until someone calls you from billing and says, we can't bill for them because they've been attested to so-and-so such and such.
They have an answer, and they're going to tell you over coffee. Any other questions, really quick? I saw your hand earlier. I don't want to leave you out because I knew I did see your hand up.
Where's the hand? Oh, yeah, I remember.
Go, Pam.
You're in trouble. I remember you from last time.
I just wanted to ask if the MCOs were doing any qualitative data from the patients themselves, asking where they think their own gaps in care are.
Ooh, I like it. They're going to tell you over a muffin. So meet them in the hallway.
We should talk about CAPS survey. Remember to ask us about CAPS survey because that's where that happens. So we'll talk about that.
Basically, what I'm planning on talking about today is strategies for partnering with the hospitals that each of your practices work with on a regular basis, because we know that hospitals are a critical part of the continuum of care. They have a lot of, they exert a lot of influence over the care of your patients, and we know that certainly many of you in this room have been working with your hospital partners for a long period of time. But as we transition, and as we have been transitioning to this program, I'd like to talk about different ways that we might, strengthen some of those partnerships. And also, I'm realizing that I think some of the people from the MCOs in here could have a significant role in helping out with some of that as well. So anytime that anyone from any of the MCOs are here that have some great suggestions, we would love to hear them. I would like this to be as interactive as possible. I have some slides that make some suggestions, but what I think the point of this whole discussion is to really get ideas from all of you, what you're doing with the hospitals that you're working with, who are seeing your members on a regular basis, and how you're working with them to help manage shortening length of stays, getting people the services they need once they're discharged, because I think you're out in the community and hospitals are not, and so I've worked at hospitals for a good chunk of my career, so I know very well that they kind of work in their own in their, I'm not going to say silo, but they work with what they know, just as you work with what you know. And so working together, I think, expands the knowledge across the care continuum and hopefully can help people get the right care at the right time in the least restrictive setting possible, and making sure that we're addressing issues such as social determinants of health, like homelessness for the seriously mentally ill population, and other and other needs that your members have that hospitals might not have as the access, as much access to as you do, because you're probably much more connected to the community and community-based resources than some of the hospitals are. Would everyone agree with that statement? I'm seeing a lot of heads nodding. So we'll talk about that a little bit. All right, so I'm trying to see where I am. Okay, so basically the agenda for this session is, how do we work with our hospital partners? What are we doing that's working? What are we doing that's not working? How could we improve the way that we do work with the hospitals that are treating the majority, well, maybe not the majority, but significant numbers of your members that are attributed to your organizations. Then I want to talk a little bit about managing care transitions, and talk a little bit about the admission discharge transfer feeds that are in the CCT, and how best to use those. And again, if people have other suggestions on how they use them, and they think they work better than specifically what I'm going to speak about here, we would all like to know that. This is all about sharing best practice information. So let's just please make this a very dialogue-heavy session. I'm going to talk a little bit about crisis intervention. You're all very familiar with the mobile crisis services and the other crisis intervention services that the state offers, which are great. So I'd like to get a sense for how that's working, how that works, and how that, where there may be gaps in those services, if there are. And then just talk about sort of how do you manage some of the challenges when you're working with hospitals who tend to want to do things their own way, and tend to have a lot of influence over how things get done, and tend to be, as I have heard them referred to in the past, as the 10,000-pound gorillas that just dictate how things are going to happen. So I'd love to talk a little bit about that as well. So let's start talking about, let's start with working with your hospital partners. It's hard for me to see this here. All right, so what are the goals? I'm going to ask you, what are the goals of working with your hospital partners? What are your goals? What do you get out of working with your hospitals? I mean, I can speak. There are words on slides, but I really would like people to speak up and talk about sort of what's working for you, what's not working for you. Yes?
So is this in the context of like hospital discharge after an inpatient stay? Or just
Yeah, so it's really, okay, so what we're really talking about is, how do we share clinical information? How do we work with our hospitals on if if we see someone's in the emergency room through an ADT information feed, if we see someone that's been admitted, how are we working with, say, the case management staff? How are we connecting our care teams with the care teams at the hospitals to help with discharge planning? Helping with discharge planning can help to shorten length of stays. Intervening if you happen to get an ADT feed that someone's in the emergency room, there could be potential to to intervene and work with the crisis management services to make sure that that patients are getting the right follow-up care if crisis management says they don't need admission, or if they do, and working with the teams, the case management teams on the inpatient psych units and on the med-surg floors, to just help with making sure that when patients are discharged, they're getting the right follow-up care, the long-term follow-up care that's going to keep them healthy, and not just the short-term follow-up care that's going to keep them out of the hospital for 30 days, because that's what hospitals tend to focus on, is just keeping them out for at least 30 days because they get dinged by Medicare for 30-day readmissions.
So I work over at Centerstone. What we do, our primary goal is just to make sure that there's I'm sorry. It's probably a lot easier to hear me now. To make sure that there's a hospital discharge appointment with our clinic, that discharge appointment is within less than a week of discharge from the hospital, so the client can more immediately follow up and attend. That the client has a stable placement whenever possible. So we do our best to work with our hospitals for them not to be discharged to the mission, because mission pretty much means, or the homeless shelter, that they won't come in for services, or there will be a failure in follow-up. So to discharge either to a family member who can be relied upon to bring them in, or to a supportive housing facility to make sure that facility can help with the management of the discharge appointments.
Great. So would you say that you have much more access to those services than the hospitals do, and are like supported housing, supportive employment programs?
So that's a delicate balance. So with housing, Centerstone does have some contracted supportive housing of our own that we utilize. So it's a bit of a 50-50. The referral has to come from the hospital, but we can make sure that it moves through the contracted facilities. But one of the barriers is housing hot potato. In Nashville, there is no housing. It's all very limited. Beds are very limited. Most of the housing in Nashville requires 2.5-time full-time jobs statistically based on median average income of the city. So it's always a challenge between the hospital and with Centerstone itself to arrange for a housing placement after a hospitalization. So it's a game of hot potato of who can find the place first.
Right. So, would anyone else like to second that, or have other experiences? Yeah, we have someone over here.
As it pertains to housing, I work for the Mental Health Cooperative and oversee some of our homeless services programs. And I think one of the key points to collaborating with hospitals is that
is a lot of times individuals may be in a state of crisis and end up in a hospital, and a key point of the collaboration is stabilizing folks long enough when they're in the hospital and working with maybe the group home or the boarding home provider to secure the housing that they were in prior to hospitalization, so that you don't have to try to create a new housing opportunity, but you might be able to work to maintain the one that they vacated when they went into the hospital.
So let me just ask this. I mean, those are great questions. So how can I just get a show of hands that from people from the PCMH programs and Health League programs that feel like they're really actively working with the hospitals that treat the majority of their patients, and they're connecting with the case managers, social workers on discharge planning? How many of you feel like you're doing a good job doing that? So a few. So a few. So what do you think? So what are some of the barriers to making that happen?
You guys might as well just give me my own mic. So it's that the infrastructure in many places in Tennessee can't support the current needs. So I really want to move away from terms like the silver tsunami, because that's inappropriate. But when we look at the level of needs that some of our TennCare beneficiaries have in Tennessee right now, there are not enough group homes, there are not enough supportive housing facilities, there are not enough skilled nursing facilities, there's not enough access to the resources that people need in order to facilitate a successful discharge from the hospital. We can get them in for meds, we can get them in for therapy, we can do that on a weekly basis, we can support them in the biological and cognitive worlds, but until the infrastructure is built in order to support people being successful, we will always be trying to play catch up.
Okay, I think we had another. Oh, sorry.
From a PCMH standpoint, we don't have the difficulty of placing with housing or anything like that, so I don't know anything of that concern. But from inpatient hospital stays for our repetitive patients, getting a case manager from the hospital is like pulling teeth. They never have enough case managers or a case manager, period, that can communicate with the PCP office or a health care office of any kind. So we don't have anything but a list, and that's if the patient tells them that we're their primary care physician. So if a patient doesn't tell them that this is their primary care physician or their mental health physician, then we have no way of knowing.
Right.
So that's our biggest thing, is having somebody integrated within the office that's going to speak to the PCMH or the THL and a care manager that's just for those patients.
Right. So the CCT, I mean, that's a tool to help. I mean, you've got member.
Our biggest hospital in Clarksville is that's the only hospital, and so we do not have them in the CCT.
Okay, so, but we know that that's a goal to get as many as possible. So right, so that should help significantly. Would you not say?
When you don't have a phone number and the call froze or it says not available and we've never seen the patient, we can't reach out to the patient. So it's a demographic issue. And we've
Right.
spoken with our NCOs about this. If they can't find the patient, they can update the demographic here.
Right.
So it's how you communicate with the patient that's gone to the hospital 15 times.
Right. So, right. So then, and how are you working with the MCOs to try to get this information?
We have contact with each MCO. So
Yeah.
I receive a report every week from the MCOs that tells me, hey, you have this amount of patients that were within the hospital. This is what we have. But if we don't have correct contact information, we can't get the 78-year-old patient that's had pneumonia 6 times in the last 12 months in,
Right.
and then
Right.
there's nothing we can do.
So the goal is to move to get all the hospitals on the CCT so that
Even
they can.
at that point, if you have no contact information for the patient, you can't get them in.
Understood.
Yeah.
Totally understood. It's a chronic problem everywhere in the country, and I'm sure there are ways that we can improve it. I'm not sure there are ways that it's always, that it's going to
Never going to be 100%.
be completely solved. Right. Are there any?
Situation in which the MCOs would be willing to provide assistance, care management assistance, with trying to track down that person that has been discharged and transitioning them into outpatient care. Good.
I think Dr. James.
So I think all of us at plans have case managers as well. And one of the things that's a big focus for those case managers is what we call transitions of care, right? When they move from one level of care to another. So I would encourage you to talk to the folks that you interface with each plan about what that looks like. I know for us, we have transition of care managers that are assigned either to hospitals or groups of hospitals, and particularly around those members who've been admitted repeatedly, then we can actually go to the hospital and try to interact and work with them at that level. If we can't get them to answer the phone at home, we might be able to catch them while they're still in the hospital, those kind of things. That won't necessarily be the solution ever for the, a single admission, but particularly for ones that are recurrent admissions. And I would encourage you to take advantage of the ability to refer those patients to us for case management when you know they've been admitted repeatedly and you can't get in touch with them. That's a reason to refer them to us for case management, and that'll help, for us to know who to go look for, because you may know about those repeated admissions before we do sometimes if we've got to wait for those claims to come through. So for those of you that have that as an issue, I would encourage you to maybe at one of those quarterly meetings make that something to talk about so that you could get connected to the right folks at the plans about that.
Is there any way that the PCMHs have access to see if their member has a THL provider?
Yes, there is, actually. If they are enrolled or if they're attributed, correct, to a PCMH, go ahead, Constance. I knew the answer was yes.
Hey, it's Constance with TenCare. The answer is yes. That information's in the care coordination tool. It's in a couple of different places because you can actually see the specific organization that the member is attributed to. And so, as Randy was kind of saying, it can either be just because they're attributed to them. If they're in an attributed, not enrolled status, that actually means that they haven't consented to receive HealthLink services from that particular HealthLink, but it may be because that HealthLink hasn't been able to find them yet. So that would be a great opportunity if they come into your facility to get that information back to the HealthLink so that they can connect to see if that member would like to receive the HealthLink services and or vice versa. I think most of the HealthLinks know at this point probably how to get the PCP information, but I think that's just because it seems like from the general read that our HealthLinks are in the CCT maybe a little bit more, but that information can be found if you go into the, My Members tab, Member Information, and then Care Team up at the top. So you can actually generate that information in the report. If you select, right now I guess it's, what does it show as? THL. Can you pull the actual THL? Perfect. There's a demo video on the website showing you exactly how to do this. So it should be under the Care Coordination Tool tab on the TenCare website where we have all of our training materials listed. And Georgette probably knows the more specifics.
Hi everyone, I'm Georgette Carusi with TenCare as well. The training, the demo that they were referring to, Carly and Constance were referring to, it's not quite up on the website yet. We do have the demo and it's being planned to be put on the website, so look for it soon. But yes, you would be able to watch the demonstration, and it'll show you exactly step by step how to find that information within the CCT. Right. So if you're within a member's, file within the CCT, if you click on their name, you'll be able to find within their member summary a care team tab, and within there you'd be able to figure out the practice that they're attributed to. So you'd be able to see that information if you were a PCMH where the member is attributed to at a THL.
Quick question, sorry. For when you guys go to the hospital to capture someone that's missing in action, so my question is, if you were to capture new demographic information, a new phone number, how quickly does that make it to the CCT tool? Is that something that we can pretty quickly capture if we're looking for them as well, or is that just the monthly feed and it'll eventually get there?
that may be something that we'll need to talk through with TennCare and get back to you guys about how quickly it happens. There are some things about, so members have to update their information. We help them as the plan, right? So I, as an MCO, can't go in and change a person's address without their permission. And so there are some things about that. We at the plans have ways that we keep, backup information. So it may be that connecting with us first, if it's something, within a few weeks of discharge, and being able to communicate with us about, hey, do you have a different phone number than we have? It will, I think, at least in those monthly feeds going forward, get caught up. It is sort of a timing issue of when the data gets to each thing, because of the need for the member, because it's their personal information to update it themselves.
So one problem we have is getting newborn nursery records from newborns, and the hospital, they have the patient there, they could sign, and we're listed as a PCP, but then they'll say that's a HIPAA, and they have to get medical record release. The patient's already, the baby's already been discharged. So in this day and age, we're still faced, and this is a recurrent problem, with making decisions without the information, because we see them like day 3. So it's that should, when the appointment is made, my front desk, we don't know about them until they're calling for the appointment. We're starting then trying to get the records, but we still are faced with sometimes hospitalizing. This happened recently, a baby with jaundice without all the information. So if one of my nurses is talking, we're at a catchment area number of hospitals, talking with the newborn nursery director of nursing, can you, as part of your discharge orders, send H&P to the PCP, or, ask for a record release, ask the parent to sign a record release. So maybe that's something that MCOs can also help, because I think sometimes people tiptoe around the HIP, that the HIP, if we're the PCP, they can send us the records. But we don't get them until day 5, and we need them day 2. So.
I think we may have more of an issue with some of the SUD records, is that correct, with the state, and exchanging some of that information? Yeah. Right, I understand that. All right, so.
Randy, we have a couple questions over here.
Oh, sorry.
I just had some feedback to share real quick. I know on the HealthLink side, we've been working really closely with the inpatient facilities and with our utilization managers to make sure that they have the health links given to the discharge planner at the point of discharge, because we can identify that in the system and send them that information and make sure that connection is at least being made. And then also, we have a couple of health links that have partnered with their local inpatient facilities, and and I know one even signed a contract to work really closely with that discharge planning and having people on site there at the inpatient facility. That's been very successful.
Great. No more questions? No? Okay. All right. So, I just would like to have a bit of a dialogue around, working with your hospital's case management staff, working with the MCO's case management staff. You've got admission, discharge, transfer information that makes you pretty much immediately aware when someone shows up in the ED. And then, presumably it would be the care coordinators at the PCMHs and the health links that are responsible for then following up as quickly as possible to help at least, get an understanding of what's going on, and then hopefully connecting the care teams with the care teams at the hospital. And I'm wondering how that process is working for PCMHs and health links. Are you successful at connecting your care teams, your primary care physician or your health link behavioral health provider with the hospital care teams that are taking care of the patients at the hospital? How is that working? And is that let's just have a dialogue about how we think that that process is going.
Thanks. We receive lists from the MCOs for current inpatients. So when we identify those patients on there and outreach to the hospitals have no clue what a health link is. And it makes it very difficult for us to try to, get into that conversation initially just by saying, we're Unity Medical Clinics on behalf of the MCO trying to contact to provide services under the Tennessee HealthLink program for this patient. They're wanting a whole lot of information about us, who we are. It makes it so difficult by the time we can get back around the patient's discharged and lost for us to try to outreach to them. I don't know if there could be, other education to hospitals that are providing services to the HealthLink patients about that, just to kind of introduce the program to them.
So, if you don't mind, Constance, Carly, do you mind speaking to that?
So that's a good point. That's actually feedback we hadn't received yet. I would say in general, I'd probably look to the MCOs that have the relationships with those hospitals directly to provide some additional education about, I'm looking at Dr. James just because she's over there, providing some additional background about the program and, that if you have somebody who gets captured in that, eligibility for the program, I think they probably are all familiar that if you have a TennCare member, that person automatically receives PCP attribution from the get-go. So it's probably also kind of a twofold education. I did also circulate, and we're working on updating some of the information in the knowledge library and the care coordination tool, some additional materials you have. But we at TennCare worked on just kind of a shorter one-pager that introduces HealthLink. And has our official logo, et cetera. I know we were getting some feedback that people were like, what is HealthLink? Is that just like you and your organization? Not understanding that it was a TennCare-led initiative. So we have that information there, and I'll make sure that we kind of recirculate it again. It was attached in one of our weekly HealthLink updates. So if there are any HealthLink administrators in the room, if you can get that down to the rest of your staff, that would be really helpful. I'll let Carly speak a little bit more about that.
Definitely think the hospitals need to know about the HealthLink program so that they can help you get the information about that member quickly. And so what I can commit to is that I'll reach out to the Tennessee Hospital Association and see if they can help us with some education, since they have the ears of most of the hospitals in the state, and we'll see if we can use that as a vehicle to educate them.
So I'd love to hear a positive story about how this is working with your hospitals, working with your hospitals. If we have someone back here. Oh, I'm sorry.
Hi, my name is Mandy Ryan. I'm with Centerstone. And so we have agreements with 3 of the psychiatric hospitals. We have hospital liaisons, a dedicated staff for each one of those hospitals that we are able to go in and see any of our clients. We can see them whether they're in HealthLink or any payer. So that has helped us to be able to make that connection while they're in the hospital, make sure they have that discharge appointment set up, and then we continue to go ahead and remind them with a phone call as well before that 7-day appointment. If they miss that first 7-day appointment, then we attempt to continue to call them and get them rescheduled back in for another appointment. If they need assistance getting transportation scheduled, we can help them. And so being able to be in the hospital while they're there, that is a service that we provide that we're not able to bill for, but we feel that it has great benefits to be able to do that. We would love to be able to be in more hospitals, but those are the only ones that we have at a time a partnership with.
And those are the state psychiatric hospitals?
One is the state and then 2 are private.
Okay. Yeah, I actually, I think that's I gave your example in my presentation since Mandy and I spoke last week. So I think that's great, and I've seen that in many other markets where primary care organizations or behavioral health organizations, CMHCs, FQHCs are responsible for managing, for the transitions of their patients. And I'm just wondering if there are any other innovative sorts of mechanisms that any of you are using to try to, similar to what Centerstone is doing, in making sure that people may actually be stationed in emergency rooms.
We are a PCMH. We have a live feed from Tenova that tells us exactly if our patients are in the emergency room, if our patients are, again, if they've told them we're their primary care physician, if our patients are admitted into ICU, NICU, any kind of feed like that, as well as if they're having surgery, we have that live update. Our owner of our practices actually sits on the board of Tenova, so he gets that rolling as far as communication and making sure that's up to date. So, and we've spoken with HCA and have access to them as well. A lot of the times it's just communication and finding the right person and letting them know, hey, we want to work in conjunction with you to make sure that we're seeing these patients and they're not readmitted, and just speaking with someone on the board to get them to where you can have access to that list.
Right. Great. Any other innovative kinds of mechanisms that you have in place? Try to help keep track of when your patients are getting admitted or showing up in the ED? The gentleman over here.
We have a similar access to the ER records and the hospital records, and we can go in and look at it. The care coordination tool, I'm happy to report that we're seeing a lot more of our hospitals there. But because we don't really know why they were in the hospital, we don't have the diagnosis information, we're still having to go in that record and try to find that. So that will be helpful. But just the plug, I guess, the successful thing is some of the MCOs. I know AmeriGroup is, I think maybe we're getting it from Blue, but we're getting sort of weekly reports from them that have loads more information about why they were admitted, whether there was, I'm trying to remember their term, but was this a reasonable admission? Was it, how many other admissions have they had? So those are very, very helpful in helping us decide how we're going to take action on that.
Great. Anyone else? Okay. Well, I'm going to skip back a little bit. I'd like to talk about the ADT feeds a little bit. All right, so just a little demo of what you can find in the admission, discharges, and transfer tool in the care coordination tool. This is a snapshot of just sort of a broad listing of what's included in the ADT information. When you click on the admission and discharges icon at the left, you can see the red highlighted icon. I've got a black and white slide here, so I hope it's red. But basically, it will show you, it'll show you the patient's name, it will give you the date of birth, it will give you the health plan, it will give you a risk score if that's loaded. It'll give you an admission and a discharge date, or if they haven't been discharged, you'll know that they're still in the hospital. So this is your opportunity to really reach out to the hospital and try to work with the case management team and the treatment team to try to work on, understand the care plan, understand what's going on, and then work on discharge planning and making sure that that your patients have the right resources once they are discharged. I also want to point out that there is, you you may all be familiar with this, but at the far right, there's a status column, and once your patient is discharged or during other basically once your patient is discharged, there's follow-up. So generally the follow-up is under the category called next activity, and you can see that there are a couple patients listed here that it lists requires 7-day follow-up. Okay, so if you look all the way to the right, you see a little orange letter I there, which basically means that someone has one of your care coordinators has started that process, but it hasn't been completed yet. If you see a green icon with a C, that means that your care coordinator has worked on closing that gap, it has been closed, and it's completed. If you see the red triangle, it means there is some follow-up care that needs to be done to close gaps, and the process hasn't started yet. So I just wanted to point that out to everyone if they were not aware that that's how that works. Then, go to the next slide. This is sort of a portion of what was on the previous slide. When your patients are in the hospital, you can find on that same ADT tab, you'll see where the patient is. You'll see whether or not they were admitted, discharged, transferred, the discharge date, if that has happened. If they've entered the emergency room, and all of that information is useful for your care coordinators. It's a trigger to reach out to the hospital and reach out and try to connect with the treatment team or a case manager or a social worker to start the process moving in terms of helping with discharge planning and ensuring that your patients are getting the follow-up care that they need and that you're closing gaps once that process starts. All right. Show you another view of an ADT summary. So if you look at this slide, this is still coming from the admission discharge tab. There's a black circle on the first column there, and if you click on that black circle, it will give you a lot more information about what's going on with the patient. And if you click on that black circle and click on ADT summary, you can see when the patient was admitted, where what facility, and even potentially admitting physician name. So and discharge date if it has been identified. But basically, there's additional information here to help you reach out to the hospitals and start the process moving. So that's a pretty important. I think when your care coordinators are looking at someone who's been admitted to the hospital or has been admitted to the ED or shown up at the ED, you'll get the feed, and then you start looking at that information that will help you get the process moving as you're trying to work with your hospitals on discharge planning and making sure that your patients are getting what they need post-discharge from a long-term perspective. I know we've talked a little bit about having some issues with not all of your hospitals that you work with are on the CCT yet. This is sort of a heat map for the state of Illinois state of Tennessee. I'm from Illinois. For the state of Tennessee, that shows the concentration of hospitals that are actively submitting ADT information. I do have specific hospitals, and I'll show you those. But basically, you can kind of see that the northeastern region is pretty much up and running. There are a lot of hospitals in the central region, and the number of hospitals in the Western region that are actually up and running and submitting ADT information throughout the state. The goal, as Carly and Constance has said, is for 100% of all hospitals that are members of the Tennessee Hospital Association to be actively on the CCT and submitting data by the end of the year. That's the goal. So if we look region by region, I've got first the West region, which probably relates to you a little bit less than your region. But at this point, we have 3 health systems, 19 hospitals, and 3,831 beds that are actively submitting ADT information into the care coordination tool, which is total, did we say we're at about? We're at 46%. So not long ago, we were at 27%. So the state's making some significant progress over the last couple months. If we look at the central region, the middle region, probably more relates to you certainly more. We've got 3 health systems that are submitting. HCA, obviously, we already heard that. Maury Regional, and Vanderbilt. And that's a total of 21 hospitals and 3,854 beds. So again, making progress. But I can leave this up for a minute if everyone would like to just, if you're not aware of which hospitals are submitting and you want to just kind of jot it down so that you know, that's fine. Otherwise, we will be sending out this presentation after the conclusion of these sessions, so you'll have it. And then, in the Eastern Tennessee region, somehow the bottom got cut off, but we've got a number of hospitals, and it's about, I think it's around the same number, maybe about 3,400 beds that are currently at submitting ADT feeds in the East Tennessee region. So again, making fairly significant process in a very short time. Any questions about this information? Comments? You're all aware of the middle region and who's submitting and who's not submitting? Okay. Already talked about this. This was sort of comment about innovative ways of having access to that information outside of the CCT if it's necessary. And then basically I want to talk a little bit about, how does it work? How should it work? Obviously the information for hospitals that are submitting is pretty much available real time. It provides you with where your patients are in the process, if they're in the ED, if they've been admitted, if they're on an inpatient unit, if they're potentially having surgery, if we're working on discharge. So it's your opportunity to really connect with the case manager, social worker, and potentially the care team to work on follow-up care once those patients are discharged so that they're getting back to your organization for follow-up, and then also any other community-based services that they may need to keep them healthy. And I'm going to talk briefly about mobile crisis services. All of you are aware of who's providing mobile crisis services in your region, so I'm not going to talk about who's providing what. I know you work with them on a regular basis, and they show up at emergency rooms to help identify whether or not there might be an opportunity for ED diversion or inpatient diversion and connecting them with your organizations when that's possible. I think one of the issues that we might have is right now, unless the MCOs and the list that they provide, right now the CCT is not going to show which PCMH or HealthLink the member is attributed to unless that member says my PCP is X or I'm treated at Y HealthLink. So I think that can be an issue in terms of identifying members.
Actually, the CCT does tell you which provider you're attributed to. It's just that the crisis intervention doesn't have access to the CCT.
Right. Well, I'm sorry. That's what I meant to say. Right. Right. So the crisis provider may not know. The hospital may not know. So if the patient isn't telling you this is who I'm seeing, then it's difficult for you to get notified that your patient is in the hospital. All that said, the crisis team does its job with trying to divert and trying to get people to the right resources, but they may not be getting them to the PCMH and HealthLink that they're attributed to. How much time do I have? Oh, you have a question?
Yes, sorry. Well, kind of a question or comment. It's kind of a follow-up to what you said. So my understanding was that the CCT tool has who we've attested to, not who was attributed to us, right?
It has who's attributed to you. Are you a HealthLink provider?
Mm-hmm.
It has all the members attributed to you.
Right. The issue is.
Also, if you've enrolled a member,
Mm-hmm.
their status is listed as enrolled. It's active. Yeah, active. And if the member's just been attributed to you, but you haven't enrolled them yet, it says attributed, not enrolled.
And so what's happening when somebody else attests to them? Do they stay in our portal? Not portal, wrong word, CCT.
Sure. So if another HealthLink enrolls that member, then that member would be in their care coordination and not yours.
So they would exit ours.
Yes.
Okay.
And if you have specific examples of where that's not happening correctly, let us know and we'll dig into it. Yeah.
Okay, so I think I'm about out of time. Does anyone have any last-minute thoughts that they'd like to contribute? Okay, well, thank you very much.
So we have two fantastic ladies up here who are working with very successful organizations. I'll let them introduce themselves. So tell us your name, your role, and a little bit about your organization.
Yeah, so I'm Andrea Westerfield, the Director of Care Management at Mental Health Cooperative. I've been there for 10 years now and actually started out as a care manager myself. Our agency has successfully made the transition to a Tennessee HealthLink, coming up on our anniversary. I guess we should all celebrate in the room, right? And we serve the SPMI population along with children with emotional disturbances, and have, I think, successfully helped transition our consumers or the patients we serve to this model of care as well.
And I'm Priscilla Stallard, Clinic Quality Coordinator of Covenant Care Family Practice. Been there for 11 years now. The practice is a family practice that carries all the way from birth to hospice, because we also deal with hospice and skilled nursing facility. And we've been in practice for over 15 years. We were NCQA Patient Centered Medical Home before we became the 10-Care one. We are also part of CPC Plus.
Awesome. Thank you. Remember Phil Donahue? That's what I'm going to do.
What is that?
So, remember Phil?
Oh my gosh.
So be ready. All right. No. I didn't like that angle. I'd rather see them from the front. And I don't want to stand up there, because they're the center of attention, not me. So I have a few questions for them, and they're specifically related to partnering with PCPs and HealthLinks. but there are a lot of other agencies and specialists to partner with as well. So we're going to have some discussion about that. But I also don't want to have these ladies having to have all the conversation, because I know many of you have established fantastic relationships with your organizations, with other organizations. So as you've been so gracious in the last 2 sessions to provide input, please do so for us here, and I'm sure Andrea and Priscilla would appreciate that as well. So let's start with you, Andrea. What led you to develop relationships with other providers?
I think it's a necessity, first of all, but secondly, just keeping consumer care at the forefront of everything we do, just thinking through what benefits a consumer, how can we be a bridge for them to effectively communicate with their PCP, but also how could we effectively communicate with their PCP, and that led us to partnerships in a couple of different ways. One of those is formal partnership or relationship with primary care physicians, and actually Covenant is one of our formal partnerships. So just thinking through what does a patient need when they go to their PCP, and we have embedded therapists within our formal partnership PCP offices and streamlined the care coordination for THL for them so that we have fewer points of contact. And then on the informal partnership side, just really trying to link up with those PCP offices who are not PCMHs or who are PCMHs that we don't have formal partnerships with, to just think through how those individual providers need communication, how can we meet their need, which in turn meets the consumer's needs. So that was what drove us to partnershiping.
Same question, Priscilla.
A big part of us is that the fact that since we are a provider for patients and not just on behavioral health, the fact that specialist reports do not always come timely to us, the fact that we cannot get patients in timely into offices, sometimes with more urgent needs, we wanted to have a medical neighborhood. Behavioral health was a big part of that. Since we are close to Fort Campbell, we see a lot of the TRICARE patients, and we have a lot of PTSD, and then we have the kids that have the needs as well. So that was our leading direction to move towards having integration with behavioral health in the clinic and us having care compacts with other specialists.
Awesome, thank you. And I really like how your perspective was from your patient's perspective and not necessarily from your convenience, which is interesting. If you look out for that, your customer or your patient, and you're not necessarily thinking, well, what's better for you, things become better for you as well. Anyone else have any relationships that they've developed, specifically PCP and behavioral health, that they'd like to tell us about before we move on?
You know, you mentioned convenience, but it is convenient. It's convenient for the patient.
Yep.
It's convenient for us as well, because we know that they're going to get the care that they need, and we're going to receive that feedback from that doctor or our counselor that we have.
And talk about a little bit, I know I'm going off script. I didn't warn you that I would do that, but so you haven't.
Hit me with it.
You'll go with it. I know you're both capable of doing that. Talk a little bit of how, Andrea, you've integrated into Covenant and what that has done for the patients there.
Yeah, so this is a partnership that we've had for a little while now, and as I said, it's integrating a therapist, embedding a therapist into the PCP office, and streamlining communication with a care coordinator if that patient or consumer is appropriate for Tennessee HealthLink, meets the eligibility criteria. And that has had a lot of benefits for our consumers. The first one is that our consumers attend their therapy appointments. It's much less stigmatizing to say I'm going to go to my PCP office, or for a parent to sign a child out of school and say I'm taking them to the PCP office and attend their therapy appointment. They're also already comfortable with their pediatrician's office or PCP office. So we've seen a lot of improvement just in attendance, which then improves symptoms and outcomes. It's also been sort of altering for our agency because we have a better understanding of how each practice runs, what their workflows are like, which are very different from our workflows on the behavioral health side. So I think we've developed an understanding of what kind of communication they need and require and would like to have, and not only what kind of communication, but how that's digested best and what format do they need that communication from us. So it's impacted our agency from top to bottom, and the first piece of that being the consumer that we serve.
And would you say that the patients that are coming to Covenant that are being seen there, is it seamless for them? I know in some other cases that the patients don't even know that it's another agency that's embedded within that facility. It's all just part of their primary care practice.
No, our patients are notified that this is a behavioral health specialist and that they are going to be seen at our clinic. But again, this is mental health co-op. We have them on our schedule, so they get a call back from us to make sure that they are coming to the appointment. We can also track them that way when they're checked in. And the specialist also calls, the day before. So we receive reports back. We receive all the screeners that he does. He actually has access to our system in case he needs to get anything from us, but normally he just walks out to one of the nurses and says, hey, I need this on this patient. That way we can make sure that he's seeing the problems that we have had in the past with the patient or the need that's there. If there's a crisis intervention that's about to happen, then we can kind of stop his therapy that's happening, and he helps us along the way with that. We can do warm handoffs. The patients have been very cooperative. We've seen better outcomes with this because most of the time if we schedule them someplace, or what's even worse is a lot of the behavioral health in Clarksville says, you can't do that, they have to call us. Well, how many of them are really going to reach out over something that they mentioned in the office visit and we know that this is a problem? Not many.
Any questions for either of them on this relationship that they've built?
And he actually goes to 2 of our offices. He also goes to our rural clinic in Erin.
Anyone else have any similar experiences that they'd like to share? Oh, come on now. Earlier you were all raising your hands and fighting for the microphone, and now, all right. I knew I could count on Mary for something here.
I can tell you from personal experience, I just recently went full-time quality and out of clinic. I was on the floor for 4.5 years. 3 of my pediatric patients have been critically affected by our mental health counselor that's integrated. He is basically someone that they go to before they go to an assistant or to their provider. He has helped them out of a situation that was very tragic to them and has actually helped them rebuild a relationship within their family. So with it being within our office, we can walk them from one door to the next, and he is very welcoming. He will go into the room with them. It's like another person that's become part of our staff, and it's very important. If you send a patient out of the office via mobile crisis, via calling to schedule that appointment, you don't know if that patient's going to actually harm themselves between going from one place to another or even come back to see you, or answer the phone when that place calls to follow up with them. But if you're calling from a place in a number that they know, they're more likely to be susceptible to going to see that counselor.
Thank you. So maybe a question some folks have they don't want to ask is, for you, Priscilla, you're going to bring this person into your office. Where am I going to put them? How am I going to staff them? What went through your mind at that time, and what did you do to overcome those potential barriers?
I gave up my nice office. because you don't want to place him in a room that's medical, per se. You don't want that table in there. They have a nice cushy couch and a desk and a chair. There's some toys, there's papers, there's adult items as well. When he goes to Aaron, he has the same thing. Aaron, he has it even better. He has a restroom in his office. And he goes outside with them and plays ball because we have large property out there. That was my first step was, yes, where was I going to put him? Well, I'm willing to give it up. I can go anywhere. I can sit anywhere. Mary knows that. I wanted the patient and that provider to have a nice space. So if you don't have this yet and you're thinking about it and wondering how or where, look at every space that you have. As long as it's a comfortable room for them to be in, then it works, and it works beautifully.
And while it's not our preference to do therapy in a closet, we have done that before. So we would literally take whatever space is available because the outcome for the consumer is just as equally great or beneficial regardless of the space that we have.
Excellent, thank you. All right, you've answered this a little bit, but kind of walk us through the steps that you took to develop this relationship and what you're doing to maintain it. Priscilla, we'll start with you.
The maintaining is easy. I don't see us ending this in any way anytime soon. Getting there, I was first turned on about this by a mayor group. They're there to thank for us actually starting this. They kind of put the bug in my ear, and we were looking towards it. When we started having problems getting patients situated with other behavioral health facilities in our area, we just thought that this would be a win-win situation. The hard part is getting someone to return your calls that you want someone in the office with you. They think you're crazy. So I almost gave up, and then one day Michael Kirshner came into our office to bring lunch and to talk to the providers about mental health co-op. And I was like, no one's called me back. I'm so glad you're here today. You're the answer to my prayers. And after that, the relationship began, and I told him our specifications of what we wanted. We needed someone that could see children for any problems they would have, as well as adults, drug abuse, alcohol abuse, marriage counseling. We wanted a one-stop shop for that patient. And it took about 7 months, I think, for them to find the right person for us. And he is a retired chaplain from the Army, which works perfect for us since we're right there by post.
Thank you. Let's hear your side of the story, Andrea.
Yeah, so kind of two perspectives. For our formal partnerships, the steps that we take, we do have a team that sort of goes out and calls on offices to just maintain our relationship, but also to talk about what are your specific needs, could we meet those needs, could we partner, and then bringing all of our departments together on our MHC side and bringing all of the key players together from the office that we're going to formally partner with and sitting down in one spot to really hash out what's going to be the best fit, how will this work, do you have space, who are we appropriate to see, all of those things. And then maintaining that, it's not just a kickoff piece, right? So, it takes 6 months to hire someone, and during those 6 months, we're checking in once a month at least or more often just to see, are we on the right track? Do you have other needs that have popped up? But then once we have the person established with our formal partnerships, it takes maintenance as well, not just walking away from that, but really checking back in. How are we doing? Do you need more of what you have? Which is a conversation Priscilla and I had this morning. Just having a point person on each side that can communicate really well has been helpful for us. What I would not want to happen is that a PCP office has to think through what the issue is and who to contact at Mental Health Cooperative. I want them to have one person that they can contact about whatever the issue is, and that person then is going to know who to get involved from our side. So that's something that's been helpful. But then from the partnerships that are not necessarily formal, right? So we have a lot of THL consumers who do not belong to a PCMH or do not belong to a PCP practice that we have a formal partnership with. So We've also thought through, what steps to take to partner with them appropriately, and being able to, much like the maintenance phase, really check in on them. What do you need? What types of communication do you need? And I know I said this before, but it's been really important for us, really thinking through how to individualize what every practice needs. While we can't do that for everyone, we can make efforts to really make our communication meaningful. So that's been the most helpful for us.
And I think a good example of that is that Dave had to go through some training, and a lot of times they'll say, okay, you can only have this many intakes a day, which is where they do all the screeners, and you have to have this many counseling sessions a day. And in 2 or 3 weeks, that can change where they move the numbers depending on if he's had some no-shows or they need to take in more. And he would just go to our schedulers and say, okay, my schedule's changing. And we're like, whoa, we have to have at least a couple weeks before this can be changed. So that's when I had to do an outreach to them to say, hey, we have patients logged for another month. Please give us some time to try to work this in, because they've already waited a couple weeks to be seen. Or we've had to reschedule their appointment once already because he was at a meeting or he was sick. So that has worked out nice to where we have that communication back and forth.
I'm glad that you brought that up. So if you could, from both your perspectives, Andrea, we'll start with you. Tell us how you went about sharing your expectations of what you expected from each other and then what they could expect from you.
Yeah, so during the initial kickoff phase, that's best done face-to-face in a sit-down meeting, just being very clear about these are the services that we offer. This is how it can be beneficial to a consumer. We do have some medical necessity and eligibility criteria we need to meet, and I know you have some things you need to meet too, but really trying to identify where those things are similar and start there, and then work towards what's different about what we need versus what the PCP office needs. And just being very clear about expectations, and again, having that one person that can be communicated with back and forth if we're not meeting the expectation or if the expectation has changed, because that does happen. And being able to address issues head on in the moment as they come, instead of having a one-time meeting where we hit a list of 20 issues. That's not effective.
And pretty much the same. They asked what our needs were, and that's when we told them what ours were. The children to the adults. For any diagnosis, we had to have someone that would adapt and possibly stop a session if we had a need, because at times it can take mobile crisis 4 hours to get to our clinic, which a lot of times is not feasible. That when that patient needs help and we have rooms full and that patient needs help. So as long as things keep going the way they're going, I don't see any change. We are asking for a second person now, so that way each clinic can have their sole counselor, which I believe will be able to fit a lot more people in that way.
Excellent. What questions do you have for these two? Or are they just that good that they are answering your questions and any expectations that you have? Is that your hand going up, sir? All right.
Hello, Andrea. Are the MCOs requiring any kind of site licensure for y'all to be able to perform your services in the clinic?
So that's an interesting question. But
there's a can of worms.
No, it's we do rent space from them. Michael Kirshner and Peggy Hoffman take care of all of those pieces. So honestly, Sean, I don't know all the answers to those questions, but we do rent space from the PCP offices.
Is there an MCO representative that would like to talk to that?
Yes. Yeah.
Can you repeat that?
If there are practitioners independently licensed, it's not a problem.
Yes.
Excellent.
And of course, we don't do any of the billing. They take care of all of that. So again, that's another plus. We don't have to worry about that.
So that's another good thing you brought up. So how did you initially address your information sharing challenges that you may have had? I know you stated that you're using they're using your EMR, so you can see that, but the other either perceived or real barriers that there were when it comes to that.
In the beginning, so we first had a person they placed in there that was temporary, who gave us everything we needed. So all the intake, screeners, all that. We received a copy of it when they were done. And if they were scheduled with a psychologist or psychiatrist at Mental Health Co-op, we received the date and everything so we could follow up and make sure we received that information as well. When David started, it was a little bit of a slower process. He doesn't like our computer too much, so he tends not to use our EHR to get his information. Again, he gets it from one of the nurses, but they print off the visit note for him just fine. It has everything he needs. I laugh because it's just a couple of our providers want to be that way too. But as we receive what we need from him, and then any consults that we've had in between his visits with the patient, we also give to him.
Yeah, and the process is similar for us in terms of information sharing. We make sure that we have releases of information and try to communicate effectively. But honestly, the nice thing is that this person's right down the hallway and can literally just stop in and say, I'm concerned about X, Y, and Z, and have that face-to-face conversation.
By a show of hands, who here has a relationship with another organization? If you're a PCP, you don't have your own in-house behavioral health, but you have a relationship like they do. Is there anyone here that's in that similar situation? Let's see, this is how I'm going to generate some opportunities here. So talk to us a little bit about that.
I'm with Unity Medical Clinics, and we provide PCP services. The West Tennessee, one clinic in Memphis, 4 clinics in Middle Tennessee. And we are embedded in the Centerstone clinics. So when our patients do come in for PCP services and a behavioral health need is identified, we will refer our patients to Centerstone, and vice versa. If Centerstone is seeing a patient that does not have a PCP, they will refer those patients to us. So we have an established relationship on that. In the Memphis area, that's a little bit different, and we're freestanding out there by ourselves, and we're actually building our clinic to provide behavioral health services as well as PCP services under the same roof. So we're working with area PCPs also now to refer to us for behavioral health services in the Memphis area. So we're working with it.
Thank you. Did I see someone back here had their hand raised? Oh, my buddy Steven over there. All
right. Rainbow Kids Clinic in Clarksville, and we also work with MHC and have an embedded therapist who comes in to our clinic, and it has been extremely successful, not only for our staff, but particularly for our patients. But the staff really enjoys this relationship because they do have access to someone in a much faster timeline, and also gives them a chance to have, or gives us a chance to have someone develop a relationship with the clinic, not just with the patients themselves, so that there's a much easier referral, if you will, because there's a relationship that's built there. And so that it has been extremely successful for our clinic in this partnership.
Awesome. Thank you. It's another opportunity for the rest of you to ask some questions of our panel. Anything? All right. You two are amazing. You are just preempting all of their questions.
I don't have a question, Rick. I have a comment.
Oh, no.
Hey!
I hear you over here, and I don't see.
We actually, to speak on that with integration with the clinical staff as well, we had a crisis within our clinical staff that actually resulted in a patient passing within our office. It's the first time this ever happened as long as Dr. Bowles has been in practice. And Dave actually did debriefing with us so that he came in, sat down with our whole staff for a whole hour and took care of us while he's taking care of patients as well. So it's been beneficial for our clinical staff as well as our patients.
He's definitely a part of our family.
Thank you for sharing that, because that's not something you typically think about when it comes to this, but one of those added benefits, I guess, is that your staff has the opportunity to receive care in a sense as well. So Andrea, we'll start with you. Let's talk about any challenges that you may have faced in developing this relationship, and if there were, what you did to overcome those.
To be honest, we've not had many challenges in developing this specific relationship, but we have definitely had our challenges with other relationships, both formal and informal partners. Just trying to think through, sometimes partners don't understand what would be in it for them or for their patient. So trying to think through the communication that we have with them to make sure we're clear about how it's a win-win for everyone, but first and foremost, a win for that consumer or patient. So that's how we've been able to overcome some of those challenges. Also challenges just logistics and space and or logistics and communication, like, well, that fax number changed or that fax number doesn't allow some, communication that we send to go directly into our EMR or EHR. So being able to think through those challenges with each individual practice, or maybe they had a bad experience and being able to problem solve with that. Also was thinking through what Rainbow was talking about barriers to refer or barriers for an intake, and just some advice I would give everyone is to think through how we, so both PCMHs and THLs, can remove the barriers for receiving and processing referrals. How can we make that simple and streamlined for both the provider and the consumer? Can we accept the information from a PCP and then reach out ourselves? And then how can that communication work well so that if a PCP sees a consumer and they notice in the CCT that they're attributed to us but they're not enrolled, being able to help notify us of how we can intervene or get involved at that point. So I think streamlining communication is helpful and can be a barrier. So it's really sitting down face-to-face or via phone and talking through and being willing to receive the feedback about your own office. I experienced, somebody tells me I experienced a barrier when I called your call center to get an intake appointment for X, Y, and Z. So being willing to receive that and do something about that, and then return the phone call to say, here's what we've done about that, and here's what you can expect in the future.
Well, from your perspective, Priscilla?
Now that we have an agreement with them, I'm not so worried about behavioral health, but we are having issues still with care compacts with other specialists. I have 2 that we are working with, but once you go and talk to them, they think you're talking about a contract and they want to back off and go see a lawyer about it, to make sure that everything's okay. And I'm like, no. This is about the patient. This is to make sure you receive everything you need. We receive everything we need after the visit, and that there's communication peer-to-peer both ways. We have the electronic system that they can have the transition of care documents sent in and out. We have direct addresses. We offer everything that we can. We just need that communication back from you. We need to know that if you're needing a doctor for your patient because they don't have a PCP, we're here for you. We can work them in the same day if we need to. We would like that from you as well. So we have it with 2 specialists. We're working, well, that's besides behavioral health, that makes 3. We're working on that with the others as well, but the care compact agreements are, it's hard.
Any questions on the challenges of developing those relationships that they haven't already answered for you? I might let them go early for lunch and keep the rest of you. Right? The person with the mic has that power, is that correct? Let's talk about lessons learned from this relationship. So we'll start with you, Priscilla.
Lessons learned. Wish we would have done this a lot sooner.
What's that? I'm sorry?
We wish we would have done this a lot sooner. A lot sooner. The patients value the service that they receive in the office. They don't have to worry about someone asking where they're going, where they're being seen. I'm just going to my doctor's office. They don't have to say anything else. We've seen a lot of patients help with this, and it's important to us because that also helps in the outcomes of their chronic conditions when they're receiving services for behavioral health to help them understand.
Andrea?
I think what we've learned is that relationships are a slow and steady build. They don't happen overnight. They have to be nurtured. You cannot set a relationship or build a relationship and walk away from it. And we have failed at that and started over, so we've learned that the hard way. We've also learned that creating win-wins is the best way to approach a new relationship. And just thinking about what patients do we share in common, or what concerns or issues do we share in common, coming at it from a place of we have more alike than we do than we have differences.
And I already know the answer, and I was going to ask another question, but you've really answered it in there. But it sounds like this has been an extremely beneficial relationship for both your practices and your patients. So if you could just sum up in one or two sentences what that means for each of your practices. Andrea?
It's been transformational for us. It's really helped us connect the dots and understand the physical health world, if you will, and it's helped us to understand how we impact that and how we impact each other.
And it is. It's an eye-opener to where when you have someone that is there for that patient, for that part of their life, that problem that they're having, that can help with the outcome of their medical care, I can't put a dollar amount on that. I mean, we have great outcomes out of this.
Excellent. And I have a question for the MCOs on that. So specifically for this relationship, those of you that work with these two specifically, raise your hands, first of all.
I'll start calling you out.
Yeah. All right, so I'm going to come over to you over here.
Come on, guys, raise your hands.
Because I know what the benefit has been for them. I'd like to hear from you what the benefit has been for that you see it for your patients and your organizations.
Well, to elaborate on what Priscilla said, we are noticing the transformation within the practice, and we appreciate any type of additional resources and partnerships that help our Blue Care patients. So we're enjoying it.
And have you really seen a difference in your population with this?
Well, I'm fairly new, but I do realize that Priscilla and I have a very good working relationship, and we collaborate on a lot of initiatives, and she's never mentioned anything related to needing services for her Tennessee HealthLink patients. One thing that we are working on is other initiatives around, diabetes and things of that nature, but I've always heard great things as it relates to this program.
I'm going to be real careful here with the mic and the speaker.
I don't know that we've drilled down into specific patient information, but yeah, Priscilla has always been open to
things that would help the practice and help their patients. So, and that's the key with, I think, PCMHs and HealthLink is being open to talking to each other and with your MCOs. I mean, we're here to help you. We just need to work together.
No, really just more of the same. I think that the biggest benefit is knowing that the patients don't have to deal with that anxiety or that stigma that they think is there with going to a mental health provider. So I think that that's been the greatest thing that we've seen, is that the patient can go to kind of like a one-stop shop.
Excellent. And some of you are aware of this and some of you aren't. Some of you participated, some of you didn't for various reasons, and there was very short notice on it. But one of the collaboratives that we held regionally were bringing the PCPs and the behavioral health folks together in a room to talk about what the perceived and or real barriers are. And we did 2 sessions in West, 1 in East, and 1 here in Middle. And when we walked away from the Middle, we had an exchange of points of contact from 2 levels. One was the executive level, who to come to talk to, and then from a patient care level, and you're doing this, I need to bypass your gatekeepers to get to someone that can give me information about this patient. And just by meeting for 2 hours on a sunny, I don't remember what day it was, in Andrea's office up there in Nashville, a lot of things happened from that. And we still have some information that we're waiting on to get out to everybody, but we plan to do more of those. So, and if that's something that you're interested in, please let us know so we can do that. Do we have?
I have a success rate related question. So how many in-house partnerships like this do you have now, and how many have you started but then had to close because they weren't sustainable?
The only in-house partnership we have is with Mental Health Co-op.
I guess so my question is, I guess, more directed toward.
Okay. You know, I think we have 20 formal partnerships. Only 1 has not worked out. And I would say the formal partnerships are 50%, right, of our partnership abilities. The other 50% really lies in those other providers that we're not formal partners with, meaning we don't have a therapist embedded. So equally are as important, but I think about 20 across all of Middle Tennessee. Yes.
We were unable to attend the collaborative this past one for the mental health. I think it was with Mental Health Co-op. Is there anything in the works for collaboratives with the other mental health facilities and PCMHs? Because I think that there needs to be some bridges closed there, and that way that we can all work together. And within other facilities, like in our Clarksville facility, the other PCMH that's active now is with Mental Health Co-op as well. And we have a large Centerstone base in Clarksville, and we would love to be able to bridge that gap there and have some kind of collaborative with them too for our patients that are seen there.
And that you provided that information to us, knowing that that's something that you are desiring. Then if you're wanting us to be involved in that, definitely we will do that and make those arrangements and make it happen. And that's what we want. That's what we want to do. And in Memphis yesterday, and one of the sessions this afternoon was talking about performance improvement and looking at specific items, and the suggestion was made, all right, we've already established these relationships now, we've had this, now let's start drilling down into these individual specific items that we're having trouble with. How can we work together to do that? So definitely a lot of opportunities out there, and we're willing to, as long as it makes sense, do what is beneficial for your organizations. Any last questions or comments before I set these two free? All right, thank you both so much. Appreciate it. Please, a great round of applause for them. And just so that you're aware, we're writing stuff on that board over there, and we won't forget it. I want you to know that. Those are items that we've put in our parking lot. We'll follow up on them. If they've already been addressed, great. If not, then we'll look to answer those questions and get those answers back to you.